Hi, good morning, everyone. My name is Jeffrey Morris. I'm a primary therapist here at Sierra Tucson. I work in the Mood Disorders and Trauma Recovery program, and I also work in addressing compulsive behaviors here on campus. I'm going to mute my webcam so that you can see my slides during this presentation. So today's presentation is going to be, here's a little bit about me before we dive in, just so you all can have. The agenda for today is we're going to be talking about definitions of self-destructive behaviors. We're going to examine some theoretical frameworks concerning the origins of these behaviors. We're going to look at these cycles of behaviors from an emotional perspective. I'll be sharing some case studies with all of you, and then I'll be speaking a bit about current treatments for self-destructive behaviors, and we'll leave some time for Q&A at the end. So the first thing that I want to discuss today is just defining what self-destructive behaviors are. To me, I view self-destructive behaviors as a process of acting against our own best interests. To me, self-destruction is when you engage in a type of behavior that's likely going to yield emotional or physical harm, either onto oneself or onto others. Another perspective is perhaps that the behavior itself might elicit some positive feelings or even help to relieve or decrease some of the cognitive distortions that a client might be experiencing, or even negative feelings that they might have about the self. For example, there's a lot of evidence to showcase that a lot of folks who engage in self-harm are actually often calmed by that self-inflicted pain. I've found that self-defeating or even self-destructive behaviors are a pretty universal part of the human experience. We might occasionally delay unpleasant situations at the expense of increased anxiety. We might even pursue exciting activities that do have potentially harmful consequences. It's often the case that we might favor short-term pleasures over long-term positive outcomes. I think for self-destructive behaviors to qualify as truly maladaptive, they really should involve the following. Is that behavior impairing daily functioning? Is it harming some of the relationships in your life? And are the behaviors very repetitive and persistent? You see here that I've outlined that certainly there's a distinction between behaviors that are consciously known to us and some that might be more subconscious driven or automatic. I've labeled sort of a wide array of behaviors that I very much think fall into the umbrella of self-destructive behaviors. A few things to note is that a lot of recent data coming out of research is showing that these rates of behaviors are particularly high among first year and second year college students. In particular, a lot of self-harm episodes and suicidal thinking has certainly increased significantly among adults during the COVID pandemic. I think we can tie a lot of this to isolation. I want to discuss a little bit about different theoretical models regarding the origins of self-destructive behaviors. Now, of course, we can start with Freud, who very much felt that self-destruction was a cathartic response to a lot of our unconscious drives that we either aren't being honest about or that we don't want to confront. I sort of think of a literary reference here. Lord of the Flies, a novel that I'm sure many of us had to read in high school, very much argues that at our core, we're all hardwired to give into very primitive, animalistic-esque urges for self-destruction. At the end of the day, this novel and Freud argue that we yearn for chaos. Now, of course, there was the cognitive revolution of the 50s that changed a lot of perspectives on self-destructive behaviors. Arguments were made that our thoughts were driving a lot of the behaviors, and that's what we could analyze to look at the origins of those behaviors. I think importantly, in 1988, Baumeister and Schau, two researchers, identified three areas of self-destructive behaviors that I think are fairly paramount to be aware of. There's primary self-destruction. That's where a behavior is designed to harm the self in a very deliberate fashion. There's counterproductive behavior, which has very good intentions, but ends up being sort of accidentally ineffective and self-destructive. And there's what I like to call the trade-off behavior. This is where The behavior is known to carry a lot of risk to the self, but it's judged to carry potential benefits that essentially outweigh those risks. Looking at self-destructive behavior from a developmental and trauma-informed lens, to me, is really the most valuable place of understanding that we need to be in as researchers and clinicians. There's a lot of research that shows that a disrupted attachment in early childhood with a caregiver is typically going to be the clearest indicator for self-destructive behaviors in adulthood. A lot of the adverse childhood experiences that could also influence these behaviors in adulthood are physical or sexual abuse, neglect, I think continuous criticism from caregivers, also perhaps repetitive experiences with family members who might very much discourage a broad expression of emotions or invalidate a child's feelings. I also think bullying at school is a very clear indicator of these behaviors manifesting in adulthood. Any sort of episodes of being routinely excluded by other children. Van der Kolk followed 74 subjects in a research study who had, these subjects had personality disorders. Some of them had bipolar II diagnoses as well. He followed them for about 4 years, and it was found that the histories of childhood sexual and physical abuse were going to be the most significant predictors of self-injurious or self-destructive behaviors. I also want to examine these types of behaviors from a neurochemical perspective. Certainly, there's a lot of research to suggest that an underdeveloped prefrontal cortex very much leads to a higher frequency of self-destructive behaviors. Oftentimes, when the amygdala gets fired up as well, either detecting danger or re-exposure to certain environments, external or internal triggers that might remind an individual of traumatic memories, these individuals will then respond with self-destructive behaviors because the behavior itself can become very self-protective. Essentially, these individuals are trying to keep their amygdala from firing up into a blazing inferno. There's also some studies to suggest that self-harm or self-destructive behaviors actually might lower the activity of the amygdala. Interestingly enough, in regards to stress responses, there's some interesting research that suggests that saliva samples show that the stress hormone cortisol is lower in self-harming teens and even some adults. So looking at all of that holistically, one could even argue that these self-destructive behaviors or patterns of self-harm actually allow for individuals to achieve a sense of drive, a sense of excitement. The area that I really very much want to focus on today that I believe really needs more research in the field is the emotion perspective. So there is a traditional belief that self-destructive behaviors are essentially the emotional anesthetic, right? I feel, therefore I drink. I feel, therefore I cut. I use drugs to avoid experiencing an emotion which I either do not want to feel or believe I do not deserve to feel. I think this perspective is true, but I also believe we cannot view things from this, shall I say, limited perspective. We need a more nuanced view. To me, oftentimes the primary motive of self-destructive behavior is emotional regulation or emotional gain. I very much propose in my work with clients that these compulsively self-destructive behaviors that might be attached to symptoms of a mood disorder, patterns of substance abuse, or trauma responses can elicit a very self-defeating but intoxicating emotional gain for clients. I feel that clients appear to develop an almost romantic-esque internal attachment to some of their most self-sabotaging cycles of behavior. The behavior itself becomes almost cognitively symbolized as a mental representation of a certain type of emotional experience. That behavior is driven by the fulfillment of some emotional need that is not being readily or consistently fulfilled in a client's daily life. I've also found in research that the dopamine release in the brain becomes very integral to motivation for folks to continue engaging in these behaviors. As the self-destructive behaviors become almost ingrained in the brain's reward system. The brain gets presented with options for healthy coping skills, and a depressed or traumatized brain essentially speaks up and says, No, thank you. I know how to cope when I'm angry and sad. I can binge eat, I can isolate, I can drink myself into oblivion. I know what I like to do, and you can't make me do anything else. And furthermore, I enjoy these behaviors because they provide me with something on an emotional level. So think of the brain in that situation as almost like the voice of shall we say, a stubborn, rambunctious small child. Here are some examples of how that internal attachment might sound for a client. Two case studies that I want to look at to flesh this out further. In case study one, we're going to look at Joe. Joe is struggling with bipolar 1 disorder. Recently, he's been utilizing substances as a way to deliberately alter his mood and achieve a state of self-induced hyperness. His patterns of behavior are deeply unsettling to his loved ones and very much leading to fractures in the family unit. On the surface, it might appear that the client is addicted to his mania and desires the use of alcohol and cocaine to enhance this feeling. He gravitates towards behaviors that allow him to live in a place of chaos making. Through therapy, we found that he latches on to substance abuse in order to invest in his mania. Mania has become symbolic in his mind as a realistic way to actually recapture the glory days of his youth. He felt joy, willingness, hope, and love in his youth. And now in adulthood, using drugs to induce mania-esque cycles of behavior actually allows him to feel cognitively young again. Chaos making has allowed Joe to cope with the feeling that his home environment no longer elicits emotional stimulation. Now, this very example does poke some holes in the trauma-centered theory of origins of self-destructive behavior. Case study 2 looks at Ben. Ben is a young adult who is typically fairly gentle-natured, peaceful, even a bit docile, maybe submissive. He was recently laid off from his job, and suddenly he has become obsessively consumed with the concept of murdering some of his former friends, leading to episodes of cutting to fuel this rage. In therapy, we found that this pattern of active homicidal ideation and self-harm was more so an indirect subconscious way to reassert some power, some control, and dominance, which he felt was lost and squandered during his recent job loss. He is overwhelmed by feelings of toxic shame and guilt, feeling like a failure. So for him, the only way to reduce or decrease this shame is to envision actually harming friends or harming himself in real time. Here, the self-destructive behavior is formed as a toxic cognitive association with power and strength. The homicidal ideation and self-harm becomes almost markedly self-empowering and allows this client to experience emotions of pride, even joy. I want to talk about some treatments and interventions for self-destructive behaviors that kind of veer us away from the DBT and CBT frameworks. There's a 2021 study by Dr. Matthew Knock at Harvard. He showed that perceived social closeness was most frequently associated with a lower risk of suicide among US Army soldiers. What I find here is that social intervention strategies are very much testable components of not just suicide prevention programs, but maybe also potential prevention programming designed at targeting self-destructive behaviors as a whole. Here, we see that sense of belonging is a protective factor. Margaret Clark at Yale is also looking at a study of how group membership, when people experience that, it's a pathway to belongingness. So my takeaway here in my argument, clinically speaking, is that a sense of belonging can actually be established through group therapy. When we implement insight-oriented psychodynamic group therapy modalities as a result of group therapy, clients feel as though they have a community. It serves as a motivator for individuals to more actively utilize new coping skills for emotion regulation. The sense of belonging here leads to outcomes of reductions in urges to engage in these self-destructive behaviors. I believe that sense of belonging might be our key to reversing patterns of these behaviors for clients. I believe that maybe the sense of belonging is almost a neurobiological template reconstructor. It whittles away at the shame-based sense of self that so often stems from unresolved developmental trauma or symptoms of a mood disorder that are very much tied to low self-worth. Another area of intervention that could be key to targeting and changing self-destructive behaviors is a theory called internal family systems. Internal family systems is the idea that we ourselves are made up of various internal entities or voices that guide us through life. But when we're dealing with trauma and a mood disorder, sometimes those internal voices run the risk of becoming disruptive, unhelpful. Essentially, the individual's internal world is affected by the external system of which he or she is a part of, right? A father's degrading language becomes internalized to the point where the client then develops an inner critic voice, fueled by father's past comments and statements. This theory suggests that internal and external systems parallel one another. The external becomes internal. Clients develop what I like to call a little bit of a dysfunctional internal family. This family becomes full of rather rowdy, unrestrained, proverbial parts that very much act as rebellious, unable to adhere to internal boundaries. I like to think of the visual of a long dinner table. I call it the dinner table concept. Essentially, the authentic self in this scenario is segregated, lost at the end of the table, malnourished, not getting access to food at this dinner party. Other parts that are internally speaking up and getting loud and dominant are hoarding all the food at the head of the table, not sharing with the authentic self. And the authentic self is feeling submissive here. And these other parts or voices that have developed from trauma or self-destructive behaviors are ruling the day and not allowing for any sort of diversity in this dinner party, right? They're not allowing for the food to be shared. And I think this is a good visual to understand that there becomes a level of dysfunction internally, and very much boundaries need to be set with these parts that have become unrestrained. The theory suggests that there are essentially four parts to us. There are the exiles, as they're called. They hold the pained experiences of the past. They sort of exist in a childlike way, not an inner child per se, but almost rambunctious, right? Sort of disordered and always speaking up and not following any rules. The manager part of us just wants to get us through the day, wants to keep a person feeling in control. Firefighter part of us sees that there's dysfunction between those two parts and tries to come in to sort of heal the situation, but it uses the healing in a maladaptive way, and the coping mechanisms become maladaptive. This leaves the authentic self really lost. I think the goal of understanding in this theory is that we can achieve balance and harmony within the internal system. The goal here is that we can differentiate and elevate the self so that the self can be the authentic leader of the system. When the authentic self is in the lead, that part of us is going to decide what other roles the other parts will have. The more disorganized parts of the self will respect that leadership and decision making of the authentic self. I think here, really all parts have to exist and lend talents to the individual, but we need to get those talents to be reflective of less extreme intentions or desires. So this can be achieved in therapy through very structured interventions and more out-of-the-box creative interventions. The idea is that a person is engaging in self-destructive behaviors because there's a little part of them that hasn't been healed, that holds on to the past traumas, holds on to those memories, and is speaking up about those memories, but not doing so in a way that is helpful to the individual or allowing them to get through their daily functioning. So that is a little bit of an overview of origins, definitions, theoretical frameworks, and current interventions for self-destructive behaviors. I do want to leave some time for questions. So let's see. Okay, so the first question I have here is, how does one implement internal family systems into therapy? Okay, so I think here there's a variety of different ways that one can do this. I've found that creative writing can be a helpful tool. For example, perhaps writing an actual letter to that inner critic voice, establishing boundaries can be helpful. I've had clients write a sort of breakup letter to marijuana, for example, talking to marijuana as if it's a girlfriend and actually breaking up with marijuana. So I think writing can be helpful in terms of speaking to that internal part of the self that very much relishes in self-destruction and informing that part that what they do and how they behave will no longer be tolerated. I think play therapy can be helpful in terms of externalizing internal parts, maybe utilizing stuffed animals or tactile objects so that the client can speak to these different parts. Art therapy and psychodrama can be helpful as well. I've had clients actually do an exercise where they craft and build a visual, sort of like think of like an elevator, and they're going up an elevator, and every time the elevator door opens, they're confronted with one of their parts that is yelling at them, speaking at them. And to counter that part, they've got to come up with a challenge to that voice, or a reframe, a restructure, a refuting statement that they can utilize to fight back against the voice. And art therapy can help you visualize some type of symbolism to allow the person to speak back to those voices. Another question that I'm getting is, are attachment disorders related to self-destructive behaviors and codependency? That's a great question. I think very much so. The book Attached is a very helpful template to use so that we can help clients take questionnaires and quizzes so that they can know what their attachment style is. I think very much when you're seeing these anxious or avoidant type of attachment styles, there can be some patterns and ties to self-destructive behaviors. So I think in many ways, when our caregivers respond to us physically and emotionally, and with just their verbalization and their facial expressions, we then learn how to think of ourselves and either love or hate ourselves in adulthood. It also informs how we engage and navigate romantic and social relationships. I'm seeing that sometimes when an attachment gets skewed in early childhood, that individual will navigate social and romantic realms quite chaotically. Another question that I see here is, what is a good resource for internal family systems? So I'm going to provide in the thank you letter some of my textbooks that I utilize in therapy with hopes that that will be helpful to you all. I see a few more questions coming in. Someone asked, can you review the soul part of the self again? Yes, I neglected that. So the soul part of the self is the idea that our authentic self is rooted in a value system. Our values make up the authentic self and a lot of our personality traits. The key of IFS is getting these values to sort of speak up and have more power in the individual's life. Okay, one more question I'm going to try to answer here. Do you think that smoking in a recovering alcoholic could be considered another form of self-destructive behavior? I think it depends on the context and the situation. But again, if that behavior itself is repetitive, compulsive, persistent, and it's negatively impacting loved ones and social, romantic, and family dynamics, I think it should be examined under the lens of self-destructive behavior. Okay, great final question that I'll try to answer. We have another minute or so. The question is, how can self-harm be depathologized instead of someone being diagnosed with BPD when it's trauma? I think that's a beautiful question. A predicament that we're currently dealing with in the field is that borderline personality disorder gets highly stigmatized. which I think is a rather unfortunate reality. And so my hope is that oftentimes we can just speak to the fact that folks often get misdiagnosed as having borderline personality disorder, when what is really happening to drive and fuel a lot of their maladaptive coping mechanisms are episodes of unresolved trauma, complex grief, neglect, mistreatment, violations by others. This allows folks to sort of cope in a certain way, and then unfortunately, us clinicians may diagnose those coping mechanisms as being under the frame of a personality disorder, and I think that things are always much more nuanced than that. Okay, that's going to be our time for today. I really appreciate you all being here with me. We will send out a thank you letter. Attached to that thank you letter will be a plethora of resources for internal family systems, and also some articles that discuss self-harm and self-destructive behavior and where current interventions stand. Thank you and have a good day.